Hello everybody and welcome to our module on metabolic acidosis. So the metabolic acidoses are the most complex set of acid-base disorders, and that's because, as we will see, there are lots and lots of causes of metabolic acidosis. In all of these disorders, the pH is reduced. That's because it's an acidosis disorder. And it's a metabolic acidosis, so this means the bicarbonate is reduced. So if you look down at the Henderson-Hasselbalch equation at the bottom of the screen, what's going to happen in a metabolic acidosis is the bicarbonate level is going to fall. That's the primary abnormality. That will cause the pH to fall, and then the response by the respiratory system will be to hyperventilate and blow off carbon dioxide, causing the pCO2 to fall. That's the respiratory compensation. And in any patient with a metabolic acidosis, the first thing you do is calculate what's known as the anion gap, and that's because this is the way we categorize metabolic acidoses. And in order to come up with a diagnosis, you need to first know whether you're dealing with a metabolic acidosis that has a normal or increased anion gap. So the anion gap is calculated by taking the plasma sodium level and subtracting the plasma chloride level plus the plasma bicarbonate level. So for example, let's imagine we have a patient with a metabolic acidosis and the patient has these values shown in the table. The sodium is 140, the chloride is 103, and the bicarb is 17. Well, the anion gap would be 140 minus 103 plus 17, and that equals 20. The normal range for the anion gap is 8 to 12, so this is increased. So this means we have a metabolic acidosis associated with an increased anion gap. And there are basically two subtypes of metabolic acidoses. One is with a normal anion gap of 8 to 12, and the other is with an increased anion gap. So the idea behind the anion gap is that in human plasma, positively charged molecules, which are called cations, are equal to negatively charged molecules, which are called anions. There's always an equal number of cations and anions, and in this way human plasma has no net charge. It has an equal number of positive and negatively charged substances. The major cation in plasma is sodium, and therefore that positively charged sodium should be equal to the total of negatively charged substances. And the important negatively charged substances are chloride, bicarbonate, and then a collection of molecules which form what's known as the anion gap. These are all negatively charged substances, and they include things like proteins, phosphates, and sulfates. So in a normal patient, if you take the sodium and you subtract the chloride and bicarb, you will get a value for this gap. And in a normal patient, that gap is 8 to 12, and that's the amount of these negatively charged anions in the normal plasma. I've cleared away my ink so I can show you that in any metabolic acidosis, what happens is the amount of bicarb is going to shrink. Now, positively charged cations have to remain equal to the amount of negatively charged anions. So when the amount of bicarbonate decreases, some other negatively charged substance must increase. In some cases, it's chloride, and when that happens, you get a non-anion gap metabolic acidosis. In other cases, what increases is the amount of substances in the gap, and when this happens, you get an increased anion gap metabolic acidosis. So in a non-anion gap metabolic acidosis, bicarb shrinks, but the anion gap does not change in size, and the amount of chloride increases, and in this way, the amount of positively charged cations remain equal to the amount of negatively charged anions. In a high or increased anion gap metabolic acidosis, the bicarb still goes down, but the chloride does not change. Instead, what happens is whatever is causing the metabolic acidosis produces some negatively charged anion. That substance increases the size of the anion gap, and therefore you have an increase in the size of the anion gap in a high anion gap metabolic acidosis. We'll start by talking about the non-anion gap metabolic acidoses, and among patients you see in the hospital who have a non-anion gap acidosis, the vast majority of them will have either diarrhea or they have been treated with sodium chloride saline infusions. In patients with diarrhea, they lose bicarbonate in the stool, so this is going to cause a non-anion gap metabolic acidosis. As we were just saying on the last slide, the bicarb is going to shrink, the chloride is going to go up, and the amount of these substances that are unmeasured, substances that aren't bicarb or chloride, is not going to change, so the anion gap will be normal. This occurs in patients with diarrhea, but it can also occur in patients who have any cause of fluid loss from the bowel. For example, patients who have a fistula between the bowel and the bladder, those patients can develop a non-anion gap metabolic acidosis. The second very common cause of non-anion gap metabolic acidosis is sodium chloride infusion. When you give a patient sodium chloride, you cause an influx of chloride ions into the body, and they are negatively charged. So looking over at our little map here, the chloride level is going to go up. That is going to drive bicarbonate into cells, and then the bicarb level will fall. The gap will not change. So therefore, sodium chloride infusion is a very common cause of a non-anion gap metabolic acidosis. Importantly, this does not occur with other types of fluids like lactated ringers. These are called balanced fluids and they contain bicarbonate. And I talk about all the different types of intravenous fluids in the video on fluids. On this slide, I've listed some of the more rare causes of non-anion gap metabolic acidosis. One is the drug acetazolamide. It blocks the formation and resorption of bicarbonate in the proximal tubule, and this can lead to a metabolic acidosis. If for any reason you lose aldosterone effects, aldosterone is responsible for secretion of acid, then the body will accumulate acid causing a non-anion gap metabolic acidosis. So this can be seen in patients with Addison's disease. It can also be seen in patients on potassium-sparing diuretics. These drugs block the effect of aldosterone. And then finally, renal tubular acidosis, which I talk about in a video all to itself, is another cause of non-anion gap metabolic acidosis. These are rare disorders of ion channels in the kidneys. And there are additional causes besides those I've shown on the screen here. The two main ones you want to know are diarrhea and sodium chloride infusion, and then these are some of the more rare ones that I think are important to keep in mind for your exams. The diagnosis of a non-anion gap metabolic acidosis is made by history. For example, does the patient have diarrhea, physical exam, and labs, and there's no specific treatment. You usually just treat the underlying cause. Now we'll move on and talk about the anion gap metabolic acidosis disorders. There are a number of these, and everyone remembers them by the mnemonic MUD piles, which stands for the first letter of all the causes of an anion gap metabolic acidosis. And so what's going on here in all of these disorders, some negatively charged anion is being created by the disorder. That negatively charged anion makes the anion gap high, and that's why these disorders are associated with an increased anion gap. All the disorders we talked about on the last few slides that cause a non-anion gap metabolic acidosis, in those disorders there is no additional negatively charged ion produced. The only problem is loss of bicarb, and that's why in those disorders the anion gap does not increase. Let's start by talking about methanol. Methanol is a solvent. You can find it in antifreeze, industrial cleaners, and also windshield wiper fluids. And if patients drink methanol, it will be metabolized to formic acid. And formic acid is very bad. It's a central nervous system poison. It also causes visual loss and coma. Methanol is metabolized by the same enzymes that metabolize ethanol, so alcohol dehydrogenase converts methanol into formaldehyde, and then aldehyde dehydrogenase converts it into formic acid, which is the toxic metabolite. And because formic acid is a negatively charged anion, it will lead to an anion gap metabolic acidosis. So the classic scenario of a methanol overdose is going to be a patient with a suspected ingestion. It could be an accident, it could be someone making a suicide attempt, it could be someone who has an alcohol disorder and consume methanol thinking that it might have alcohol in it. The patient will be confused on exam, they may appear inebriated, and they will complain of visual symptoms, and it's high yield to remember this. A patient with an anion gap metabolic acidosis who complains of visual symptoms almost certainly has methanol poisoning. And then of course the serum testing will show a high anion gap metabolic acidosis. The diagnosis is made by measuring the serum methanol level. It will be high. And the treatments are to inhibit alcohol dehydrogenase. If we go back to this slide, alcohol dehydrogenase metabolizes methanol into formaldehyde, which then becomes formic acid. So if you inhibit this enzyme, then you'll decrease the amount of formic acid, and that will improve the acidosis. There are a couple of ways to inhibit alcohol dehydrogenase. One is to simply give the patient ethanol, which is what's found in regular alcohol. There's also a drug called fomepizole. It goes by the trade name Antizol, and it's an inhibitor of alcohol dehydrogenase. Our next cause of a high anion gap metabolic acidosis is ethylene glycol poisoning. Similar to methanol, ethylene glycol is a solvent. It's found in antifreeze and cleaners and windshield wiper fluids, and it's metabolized into two substances that are toxic to the kidneys. One is glycolate and the other is oxalate. Glycolate is toxic to the renal tubules, and if you've watched the video on nephrolithiasis, you know from that video that the most common form of kidney stone is a calcium oxalate stone. So in any patient with ethylene glycol poisoning, that patient will make lots of oxalic acid, which is also called oxalate, and therefore that patient is going to have lots of oxalate in their urine, and they are going to develop calcium oxalate crystals and calcium oxalate kidney stones. So the classic scenario of a patient with ethylene glycol poisoning is going to be a suspected ingestion for any of these reasons, just like we talked about with methanol poisoning. However, in contrast to methanol, there will not be prominent visual symptoms. Instead, there will be symptoms that indicate kidney problems, things like flank pain from kidney stones, oliguria, anorexia. These are all signs of acute renal failure and the development of kidney stones. And then an acid-base evaluation will show a high anion gap metabolic acidosis. The diagnosis can be made by measuring the serum ethylene glycol level. And the treatment is the same as for methanol. It's to inhibit alcohol dehydrogenase. If we go back to this slide, remember that these are the toxic metabolites of ethylene glycol. So if you inhibit alcohol dehydrogenase, which catalyzes the first step in ethylene glycol metabolism, the amounts of these toxic metabolites will go down. And the options for inhibiting alcohol dehydrogenase are the same as they are for methanol. These include fomepizole and ethanol. And then ethylene glycol is a dialyzable substance, so these patients can be referred for dialysis to clear the ethylene glycol out of their system. Our third cause of a high anion gap metabolic acidosis is propylene glycol. This is another solvent like methanol and ethylene glycol. It's found in antifreeze because it lowers the freezing point of water. It's used as a solvent for IV benzodiazepines, and there have been case reports of propylene glycol toxicity from patients who are receiving lots of IV benzodiazepines. It's metabolized into a couple of negatively charged anions. Remember, in all of these disorders, there's some negatively charged anion being produced. In the case of propylene glycol, the negatively charged anions include pyruvic acid, acetic acid, and lactic acid. The main clinical feature of an overdose of propylene glycol is CNS depression with a high anion gap metabolic acidosis from lactate and some of the other acids that are produced. There are many other effects of propylene glycol that have been described. Some of these I've listed here. These include hemolysis, seizure, coma, and ultimately multi-organ system failure. There are usually no visual symptoms or nephrotoxicity, and this is how you can distinguish propylene glycol poisoning from poisoning with methanol or ethylene glycol. And the treatment is usually dialysis, sometimes with fomepizole to inhibit alcohol dehydrogenase. Although in contrast to methanol poisoning and ethylene glycol poisoning, there's very little data supporting the use of fomepizole in treatment of propylene glycol poisoning. I just want to pause here and mention dialysis. Normally we think of dialysis as a treatment for acute or chronic renal failure, and many of the common indications are things like hyperkalemia and uremia, but there are certain forms of poisoning where dialysis is particularly effective, and three of them are methanol, ethylene glycol, and propylene glycol poisoning. All three of these are causes of high anion gap metabolic acidosis, and in all three of these conditions you can use dialysis to remove the parent substance and the toxic metabolite from the serum. Let me briefly mention something known as the osmolar gap, which can be helpful in determining the cause of a metabolic acidosis. Under normal circumstances, the serum osmolarity is mostly determined by sodium, glucose, and urea, and there is a formula you can use to calculate the expected osmolarity of plasma. It's equal to 2 times the sodium concentration plus glucose over 18 plus urea over 2.8. And if you calculate the osmolarity using this equation, it should be very close to the measured osmolarity if you measure it in the laboratory. So the osmolar gap is the difference between the measured osmolarity in the laboratory and the calculated osmolarity using this equation shown here, and a normal value is less than or equal to 10. And when the osmolar gap goes up and becomes elevated, it means there's something in the plasma other than sodium, glucose, and urea that is causing the osmolarity to increase. Some of the things that can do this are mannitol, which is an osmotic diuretic, and also methanol and ethylene glycol, which are both causes of a metabolic acidosis. So if you have a metabolic acidosis and the osmolar gap is increased, it suggests one of these two substances here are the cause of the metabolic acidosis. So back to our mud piles list of causes of anion gap metabolic acidosis. We've talked about methanol, ethylene glycol, and propylene glycol. And I like to talk about those three together because they're all industrial solvents that can lead to an anion gap acidosis. Now we'll move on and go through the rest of the mud piles causes, and we'll start with uremia. So uremia as a cause of anion gap metabolic acidosis refers to patients with advanced kidney disease, and the word advanced is very important here. In patients who have mild early kidney disease, they will not develop an anion gap metabolic acidosis. Instead, they develop a non-anion gap acidosis. And that's because they have problems excreting acid and reabsorbing bicarbonate from loss of tubule function, and this leads to a non-anion gap metabolic acidosis. But in patients who develop uremia, which means a very high level of BUN and advanced kidney disease, these patients develop a problem excreting organic acids. Organic acids are things like phosphates, sulfates, urate, and other substances. And when you accumulate these organic acids, that's going to be accumulation of a negatively charged anion, which, as we have talked about, will cause an increased anion gap. And the treatment for this cause of anion gap metabolic acidosis is dialysis. Next, let's talk about diabetic ketoacidosis, or DKA. This is a complication of diabetes that usually occurs in patients who have type 1 diabetes. What happens in this condition is insulin requirements rise, but they cannot be met. This is often triggered by infection or some other stimulus to the sympathetic nervous system. When hormones like epinephrine begin circulating, those hormones raise the serum glucose level. When this happens, you need insulin to bring it down, but if you are a type 1 diabetic, you don't have insulin, so as a result, significant hyperglycemia develops. In addition, because there is not enough insulin around, fatty acid metabolism occurs and produces lots of ketone bodies. In particular, it produces beta-hydroxybutyrate and acetoacetate, both of which are acids and can cause a form of acidosis called diabetic ketoacidosis. So these patients present with polyuria and polydipsia from hyperglycemia, which causes an osmotic diuresis. They also classically develop GI symptoms like abdominal pain, nausea, and vomiting. Diabetic ketoacidosis is the classic cause of Kussmaul respirations. Kussmaul respirations are deep, rapid breathing that occurs in patients who have an acidosis who are trying to blow off carbon dioxide. You can see this in any patient with an acidosis, but the classic cause is DKA. And then serum testing will show a high anion gap metabolic acidosis because of the ketones. The L in mud piles is for lactic acidosis. Anytime there's low tissue oxygen delivery, cells in the body will switch from aerobic to anaerobic metabolism, and when this happens, pyruvate will be converted into lactate, and this will lead to a high level of lactic acid, and the high level is usually greater than 4 millimoles per liter. When it's this high, patients are considered to have a lactic acidosis. Because lactic acid is a negatively charged anion, as we have been discussing, this will lead to a high anion gap metabolic acidosis. So what causes low tissue oxygen delivery? Well, there are many causes. Any cause of shock will decrease tissue perfusion. Patients with ischemic bowel develop lactic acidosis. Metformin is associated with a lactic acidosis, especially if this drug is given to patients who have renal failure. Metformin is a drug used for treatment of diabetes. And then finally, as we'll talk about in a bit, seizures cause patients to contract their muscles over and over again, and this can lead to hypoxia in muscle tissues, and that can cause a lactic acidosis. There's usually no specific therapy for lactic acidosis other than treating the underlying condition. So in patients who have shock, these patients are given fluids and vasopressors and inotropes. Surgery is the treatment for ischemic bowel, or patients who have metformin, you stop the drug. And in patients who have had a seizure, they will almost always have a post-ictal acidosis, and there's no treatment required for this. Don't get this wrong in a board question. A patient with a seizure who has a low bicarbonate after the seizure requires no treatment. That will resolve on its own. The I in mud piles is for iron, so patients with acute iron poisoning can develop an anion gap metabolic acidosis. Let's briefly review the clinical findings in patients who have iron poisoning. Initially, they get GI symptoms, and it's high yield to remember this. Any patient with new onset GI symptoms, you should think about iron poisoning, especially in a board question. In the first 6 hours, iron is toxic to GI mucosal cells, and this will lead to abdominal pain. And abdominal pain is the classic early symptom of a patient with iron poisoning. This has implications down the road because weeks later, these patients will develop a bowel obstruction from scarring left behind from the damage to the GI tract by iron. After the initial gastrointestinal phase, at about 24 hours, multiple systems develop toxicity from iron poisoning, and this can lead to multi-system failure. In the cardiovascular system, patients can develop shock. There's a coagulopathy associated with iron poisoning because iron inhibits thrombin formation and action, so patients can begin bleeding. There can be liver failure, which can worsen the coagulopathy because clotting factors are not produced normally. And there can be acute lung injury. And it's during this later phase that patients develop an anion gap metabolic acidosis. The acidosis can be severe, and it happens for two reasons. First of all, lactate is produced from hypoperfusion related to shock, and so the accumulation of lactate causes an anion gap metabolic acidosis like we discussed earlier. In addition, ferric ions get into the body, and these are very bad in terms of acid-base status. So if you look at the bottom of the screen, a ferric iron is a 3+ iron, and it can form 3 protons, which means a lot of acid. So the combination of the lactic acidosis plus the ferric iron can lead to a severe anion gap metabolic acidosis and iron poisoning. The diagnosis is made through measurement of the serum iron level, and then there are a couple of treatments for iron poisoning. The first one is GI decontamination. This involves using activated charcoal and GI lavage to try and get the iron out of the stomach. And then the second treatment option is deferoxamine. It's an iron chelating agent, and it binds to all that Fe3+ iron in the plasma. It forms a substance called ferrioxamine, which is water soluble, and this will allow the iron to be excreted by the kidneys. Next cause of anion gap metabolic acidosis is isoniazid, or INH. This is a tuberculosis antibiotic. And if you overdose on this drug, you will develop seizures. They are often severe refractory seizures, a condition known as status epilepticus. And all seizures, including those from isoniazid, as I mentioned before, can cause a lactic acidosis. So this is really of historical interest. Years ago when isoniazid first came on the market, sometimes patients would take too much and develop lactic acidosis. We don't see this that commonly in the modern era. But in any event, isoniazid can cause seizures, which lead to a lactic acidosis, and that will lead to an anion-gap metabolic acidosis. And the treatment for this condition is anti-seizure drugs to stop the status epilepticus. The major problem is not the anion-gap acidosis, it's the status epilepticus. The S in mud piles is for salicylates, and salicylates are any drug that has a chemical formula similar to salicylic acid. And the main salicylate used in modern practice is aspirin, which is acetylsalicylic acid. If you overdose on aspirin, you will develop two acid-base disorders. Shortly after ingestion, a respiratory alkalosis occurs. This is because salicylates stimulate the medulla directly and trigger hyperventilation. So this will cause the CO2 level to get low, and anytime the CO2 level gets low, that leads to a respiratory alkalosis. A few hours after ingestion of an overdose of aspirin, an anion-gap metabolic acidosis will occur. This is because salicylates interfere with oxidative phosphorylation inside of cells. So these cells start to accumulate all sorts of intermediates of metabolism that are acids, things like pyruvate, lactate, and ketoacids. You can make a diagnosis of an aspirin overdose by measuring a serum salicylate level, and the treatment is through urinary alkalinization. If you administer some form of bicarbonate to the patient, the urine will become alkaline, and that causes the aspirin to be excreted more rapidly. So here's a summary table showing everything we've talked about in regards to anion-gap metabolic acidosis. These are the causes here, which you can remember by the mud piles mnemonic. I've listed some brief information about the mechanism by which the acidosis occurs. Here's some information on the diagnosis of each condition and a few details on the treatment for each condition. Now, when I was in training, the mnemonic I was taught to remember the causes of an anion-gap metabolic acidosis was mud piles. But there is a newer mnemonic that you may hear, so I'll just mention it now, and it's Goldmark. It's basically the same things with just a couple of differences. So the Goldmark mnemonic says that the G is for glycols, which are ethylene and propylene glycol, as we have already discussed. The O is for oxyproline. So oxyproline is a metabolite of acetaminophen, and people who take therapeutic dosages of acetaminophen, which is Tylenol, chronically will develop a high level of oxyproline, and this can lead to an anion-gap metabolic acidosis. This is completely separate from Tylenol overdose. Acetaminophen overdose causes liver failure. This is not that. With oxyproline, it's just a metabolite that's produced, and if you take acetaminophen or Tylenol every day, this can accumulate in the blood, leading to acidosis. The L is for L-lactate, which is the same thing as a lactic acidosis. The D is for D-lactate. So D-lactate is produced usually by bacteria. So rarely patients can develop a lactic acidosis that is different from the usual lactic acidosis. It's a D-lactic acidosis. And these are usually patients who have had surgery on their gut so that too much starch is delivered to the large intestine where bacteria metabolize it into D-lactate. And then the other elements of the Goldmark mnemonic are things we've already discussed. They include methanol, aspirin, renal failure, and ketones. Let me briefly remind you here that hyperventilation is the normal respiratory compensation to a metabolic acidosis. This will lower the PCO2 and raise the pH. So in any patient with an acidosis, that patient will be hyperventilating. Remember, they may even hyperventilate with those big deep breaths, which are called Kussmaul respirations. Those are classically associated with DKA, but they can be seen in any form of acidosis. I'll finish with one slide on Winter's formula. So in any metabolic acidosis, the respiratory compensation is hyperventilation, like we just discussed. And hyperventilation causes a fall in the PCO2, which leads to a compensatory respiratory alkalosis. This is the normal response to a metabolic acidosis. What Winter's formula does is gives you the expected PCO2 that should be present in response to an acidosis. And if the actual carbon dioxide level does not equal the expected based on Winter's formula, then you have a mixed disorder. So if you look at the bottom of the screen, Winter's formula says that in a metabolic acidosis, the PCO2 should be 1.5 times the bicarb concentration plus 8 plus or minus 2. So anytime you have a patient with a metabolic acidosis, especially in a board question, but also in real life, you want to immediately check Winter's formula to make sure that the PCO2 you have measured is equal to the PCO2 expected based on Winter's formula. If it's not, then that patient has a second acid-base disorder, and therefore there is a mixed disorder present. And that concludes our video on metabolic acidosis.